Thank you for choosing Access On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Access is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Hello again from Access. This is Jennifer Gibson, your trainer. As you know, I'm a registered nurse with over 24 years of home health experience, and today I'm here to talk with you about the updated home health conditions of participation, and we're doing our final part of the 7-part series. Part 7 is emergency preparedness, and that's what we're going to focus on today. As we said in the previous session, Part 6, emergency preparedness is now tied into the home health conditions of participation. However, it does have its own final rule. So emergency preparedness will go into effect with a different timeline than the home health conditions of participation as a whole. So today we're going to talk particularly about the emergency preparedness and how it plays into the updated conditions of participation for home health. Our objectives today are to learn why emergency preparedness is important, to become knowledgeable of the required standards in the conditions of participation, to identify the date in which compliance must be reached, and to understand the minimum agency needs in order to comply with emergency preparedness regulation. Before we go into the changed conditions of participation for home health, let's look at our current conditions of participation and what CMS has said about the COPs as far as emergency preparedness. In particular, CMS and the government has said that the current conditions and the current emergency preparedness rules didn't go far enough in ensuring providers and suppliers are equipped and prepared to help protect those they serve during emergencies and disasters. So what we're seeing in our current regulation, both with the conditions of participation, which traditionally now to date do not have emergency preparedness as a condition at all, and even more in the emergency preparedness rules up until this point, CMS said that the rules didn't go far enough in ensuring providers and suppliers are equipped and prepared to help protect those that they serve during emergencies and disasters. So if you read the proposed home health conditions of participation rule that came out back in 2014, and then you went ahead and read the final rule that came out in January, what you notice is that the proposed rule did not have emergency preparedness conditions in it at all. Now, there was a separate emergency preparedness final rule for all Medicare and Medicaid providers, and that was published back in September of 2016, and it had an effective date of November 15th of 2016. The goals of that new emergency preparedness regulation was to address systemic gaps, establish consistency, and encourage coordination between all the different settings in which healthcare is delivered in the U.S. So after that was published in November of 2016, our final rule for the home health conditions of participation came out January of 2017, and lo and behold, we see these emergency preparedness rules plugged into the COPs. And so that's how they became part of the home health conditions of participation. Now, with that, I need to go on and tell you, and hopefully we may say this more than once, so forgive me if I do. Because we have an effective date of November 15th of 2016 for the emergency preparedness rule, we have a compliance date of November 15th, 2017, regardless of the conditions of participation as a whole. We will, as a home health entity, have to make sure emergency preparedness guidance is met and the rules are met by November of 2017, no matter when the COPs go into effect. And currently we know, as of the date of this recording, we currently know that the COPs are proposed to be pushed off until January of 2018. They may even get backed up more than that. We have not yet seen the final rule for the delay of the COPs. But we do know that that proposed rule that would delay the COPs delays those from July the 13th until potentially January 13th of 2018. So just keep all of that in mind when you're thinking about COPs and emergency preparedness. Although emergency preparedness is now a piece of the COPs, we have to meet the emergency preparedness plan in order to get our Medicare money. That does not mean that we have until the COP compliance date to be compliant with emergency preparedness. Those are two different timelines, okay? We're going to talk about that more probably. What does that mean to you? That means your agency will need to ensure that emergency preparedness plan is in place, it's updated, and it's tested by this November of 2017. There are 2 emergency preparedness exercises required to comply, and that's a desk exercise and then a full-scale community exercise. Some things to think about when you're talking about your emergency preparedness plan and what you need to do between now and November for your desk exercise and your full-scale community exercise. Think about your updated census. Do you have access to, on a daily basis, a current updated census, including triage codes and such for your patient? Are you able to identify and update the patient's acuities and risk levels? Do you have a written emergency preparedness education for your patients? That's part of the new regulation. Have you completed a hazard vulnerability assessment? Have you designated an incident command post? Where are you going to command from if there's a disaster or an emergency? Do you have an emergency preparedness plan and policy in place at all? You should, because as of 2003, we had regulation that said we should. Is your current employee contact information up to date? Do you have employee emergency contact information? Have you provided education to all the staff on your emergency preparedness policy? Have you held an emergency preparedness drill this year? Do you know how to reach your community emergency preparedness agencies? Have you communicated with your community emergency preparedness team? Do you have a plan for securing medical supplies during an extended emergency? Do you have a plan for transportation in case of emergency? Have you created a business continuity plan? And just as important, do you have an alternate means of communication should cell phone towers be knocked out and telephones no longer work and so on? How are you going to communicate with patients and employees if that happens? All of those are pieces of your emergency preparedness plan that you'll need to look at. As we go forward, I want you thinking about all those questions, okay? The actual regulation for emergency preparedness as it relates to the home health conditions of participation are found in the 484 section for home health services under subpart C, and we actually see the regulation at 484.102. At 484.102, Emergency Preparedness Preamble, we see that the agency has to comply with all applicable federal, state, and local emergency preparedness requirements. The agency must establish and maintain an emergency preparedness program that meets the requirements of this section, meaning the section 484.102. The emergency preparedness program must include, but not be limited to, the following elements. So these are the things that we have to pay attention to. First of all, this is not just a matter of complying with federal regulation. We must also comply with any state regulations, which may be more or less stringent than the federal regulation, and also our local regulation. Now remember, depending on your coverage area, your local regulation may encompass several different counties or local municipalities. So you're going to have to pay attention to and really dig and find out what the regulations are for your coverage areas. At 484.102A, we see that the agency must develop and maintain an emergency preparedness plan that must be reviewed and updated at least annually. So that's a key thing to know. You may have an emergency plan in place right now. With the new layers of regulation, you'll need to make sure that that plan meets the current regulation and standards, and that you maintain that plan and that it's reviewed and updated at least once a year. So you're going to want to pay attention to when you last updated your plan and reviewed it, and make sure that you're within a year's time. Your plan must do all of the following. Number one, it has to be based on and include a documented, facility-based, and community-based risk assessment utilizing an all-hazards approach. And what they mean by all-hazards approach, you're going to see some examples of this toward the end when I give you some examples of a checklist. You have to look at where you are located and with the areas that you serve and figure out all of the possibilities that you're at risk of having a problem with. For example, are you at risk for floods? Are you at risk for hail? Are you at risk for severe thunderstorms, tornadoes, ice storms, hurricanes, chemical spills, all kinds of things, an all hazards approach. So you have to document your risk for those different things, and it needs to be an all hazards encompassed plan and assessment. One thing I will say, when you get in touch with your Community Emergency Preparedness Center, you might ask them if they've already done an all hazards approach for your area, and if so, use theirs. Don't worry about doing this yourself, or at least make sure it's consistent and that it matches, okay? Because you don't want to put down that you're at risk for earthquakes when they are saying, no, we're really not at risk for that where we live. The second part of your emergency preparedness plan regulation says that you must include strategies in your plan for addressing emergency events identified by the risk assessment. So if, for example, you realize that you are at risk for an earthquake in your area, you have a strategy to address an earthquake should that happen. Or, you're training your patients and your employees on what to do if there's an earthquake. Are you teaching them? Are they aware of who they need to contact and when they need to implement the plan and so on? At 484.102A3, our emergency preparedness plan must address patient population, including but not limited to the type of services the agency has the ability to provide in an emergency, and continuity of operations, including delegations of authority and succession plans. Now, this is multifaceted here. Let's think about this. What is the population you serve? Do you only serve geriatric patients? Do you serve workman's comp patients? Do you serve pediatrics? You need to think about the population that you serve and make sure that you're addressing all those different entities. If you have pediatrics, for example, who are on ventilators or other equipment that requires electricity at all times, are you prepared for that ahead of time? Have you trained that caregiver on what to do if there's an emergency and they lose power? Have you contacted the power company to let them know that you have a device-dependent or DME-dependent client that needs their power restored right away? Do you have backup in case? All of those things have to be taken care of. And you also need to know what kind of services that you have the ability to provide in an emergency. When you're coordinating with your community emergency preparedness center or plan or team, you need to communicate with them what their needs might be. So maybe they need to contact you if there's an emergency, and since you're going house to house in this area, you might even be called upon to coordinate going house to house to help the EMTs. I don't know what that might be, but certainly you have to know what types of services you can provide in an emergency and coordinate that with your local emergency preparedness team. Also, the continuity of operations, including delegations of authority and succession plans. You need to have in place in your emergency preparedness plan, for example, what would happen and who is going to be in charge should your administrator and alternate administrator not be available. If something happens and you can't reach them, you don't know where they are, you don't know if they've been hit by a tornado, whatever, who is in charge when they are not in charge. That needs to be in your plan as well. At 484.102A4, we see that our plan should include a process for cooperation and collaboration with local, tribal, regional, state, and federal emergency preparedness officials' efforts to maintain an integrated response during a disaster or an emergency situation, including documentation of the agency's efforts to contact such officials and, when applicable, of its participation in collaborative and cooperative planning efforts. So basically what they're wanting us to do is to call all these different entities and work together and collaborate what we're going to do and how we're going to communicate and how we're going to assist if there is an emergency or disaster. The first step in that is likely going to be educating these different entities as to what home health workers do, because a lot of people don't really know what home health does and what we're capable of. As a matter of fact, in a lot of the reading that I did in the emergency preparedness preparation, we see that CMS and other healthcare entities believe that our best use is to send us to the hospitals or facilities to supplement staffing in case of disaster, when really we are most capable of providing home health services or health services in an alternate setting altogether, because we do that every day. We work around patients in their home all the time. We move about the community and get around fallen trees and bad traffic, and we're used to those things, whereas people who work in a hospital every day may not be best at that. So we probably are going to have to educate these different entities first and foremost about what we're able to do. The second part of that is going to be figuring out what all they need done and how we can fit in to helping them achieve their goals in an emergency. And in order to do that, we really need to know what it is that we are able to provide. We don't want to commit to things, and then when it comes down to having an emergency or disaster, we can't meet those needs. So really put some thought into what it is that you can provide if there's an emergency, how many staff members you have, what areas you cover, what kind of supplies you have on hand, and what you can actually help out and do in the community, and then communicate that with all these different officials' offices. And as you have those conversations with them, be sure that you're documenting the efforts to call them. Maybe at first they don't want to talk to you because they don't know what you do exactly, or they don't think that it's important to fool with you in emergency situations. But continue to be proactive and document those calls. And then when you finally get their ear, document the cooperative and collaborative efforts that you have going forward. At 484102B, we start to see the policies and procedures that are required in our emergency preparedness plan. Now, the agency has to develop and implement emergency preparedness policies and procedures based on the emergency plan set forth in paragraph A of this section. That's what we just covered. The risk assessment at A1, and we're going to see that toward the end of our presentation today. And then the communication plan, which is paragraph C that we're going to get to next. The policies and procedures must be reviewed and updated at least annually. I can't say that enough. You need to make sure that your policies and procedures, as well as your plan, is reviewed and updated at least annually. At a minimum, your policies and procedures have to address the following. So Part A, we talked about what our plan looked like. Part B, we're going to talk about what our policies and procedures look like. At B1, we see that our policies and procedures must include the plans for the agency's patients during a natural or man-made disaster. Individual plans for each patient have to be included as part of the comprehensive patient assessment, which must be conducted according to the provisions at 484.55. So basically, if you have to conduct a comprehensive patient assessment on this person, then you need to make sure you have an individual plan for what you're going to do if there's a natural or man-made disaster. At B2, we see that our emergency preparedness policies and procedures must inform state and local emergency preparedness officials about home health agency patients in need of evacuation from their residences at any time due to an emergency situation, and that has to be based on the patient's medical and psychiatric condition and home environment. So you have to take in, as you're assessing this patient, you also have to assess their environment, their psychiatric condition, their medical condition, and assess whether or not, for example, this patient's going to be able to get away if there's an emergency situation. Do they have caregivers at home during times when an emergency might occur? And if not, what's the alternate backup? Are they going to be reliant upon EMS services, or would there be a neighbor who would step in and come in and help this patient leave home? Those are the types of things that we're now assessing, and we must have policies and procedures on how we're going to do that. The third part we have to see is that the procedures to follow up with on-duty staff and patients to determine services that are needed in the event that there's an interruption in services during or due to an emergency. The agency has to inform state and local officials of any on-duty staff or patients that they're unable to contact. So tornado hits during the middle of the day, you got staff all over the Metroplex, or if you're not in a city, you're all over the county making visits, and a tornado hits somewhere in that area, you start calling all your employees. You calling employee emergency contact list to see if they made it home, and you can't get all of your employees after multiple attempts. You're going to start letting the state and local officials know of that. You're going to do the same for any patients that you're unable to reach. You can't assume they're at the doctor's office. You're going to have to figure out, did they make it there? Did they leave already? All of that. That's a lot of coordination. So you're going to need to have policies and processes in place as to how you're going to divvy up those call lists. Who's going to call whom? You can't wait necessarily, or I should say you could. It's not a good idea to wait until an emergency happens to start trying to figure that out. You should have policies and processes in place already. At 484.102B4, we see that our policies and procedures must include a system of medical documentation that preserves patient information, protects confidentiality of patient information, and secures and maintains the availability of records. So your medical documentation, first of all, I hope you're not still on paper, okay? Because needless to say, if you're on paper, emergency preparedness plan becomes a whole lot cumbersome and problematic for you. You certainly cannot maintain documentation on paper and protect confidentiality and maintain the availability of records during a disaster if it's all on paper. You don't have time to run to the office and make copies and such as that during an emergency. Second layer of that is to find out if you're using electronic medical records. You want to find out from your provider, your vendor, how that information is stored and how you can reach that information. Does it have offline capabilities? Can you still get to the patient's plan of care if you don't have power, for example, right? So does it have a mobile app? That's what I'm trying to say. If you don't have power, are you able to get to the server? So if you have a server-based software, what you want to find out is how is that server affected during power outages or during an emergency. And if you're a cloud-based software like we are here at Access, you shouldn't have to worry because as long as that information is uploaded into the cloud, you're good to go. And certainly we have mobile offline capabilities where you can continue to assess your patients and get to their medication lists, their contact lists, their plan of care, all of that in a mobile application, so you don't have to worry about interruptions with service. You also want to know from your vendor whether or not they have replicated storage facilities for data. If it's a server-based software, how often and where are those servers replicated? If it's cloud-based, you don't have to worry about replicating that, but certainly ask just the same to make sure that you're clear about being able to get to those records. The next layer you have to worry about here is what happens if the cellular towers go down and or you don't have access to EMRs. Then what do you do? So you may have to have some type of at least basic paper structure with triage codes or something that you can use to make sure you're able to take care of these patients as a worst case scenario. That should be a last-ditch effort, perhaps, but certainly you need to think about those things in your emergency plan and make sure that you have what you need to deliver the right care to the right patient. At B5, we see that the agency must develop and implement emergency preparedness policies and procedures that address the use of volunteers in an emergency or other emergency staffing strategies, including the process and role for integration of state or federally designated healthcare professionals to address surge needs during an emergency. So we have to think about if we have, let's say, federal CDC. Let's say that we had some kind of crazy outbreak emergency, biohazard exposure, and the CDC is on site. We have to figure out how we're going to integrate those healthcare professionals or surge needs in an emergency. All right, then we get into our communication plan, and this is going to be probably a biggie for most of us. At 484.102C, we see that the agency must develop and maintain an emergency preparedness communication plan that complies with federal, state, and local laws and must be reviewed and updated how often? At least annually. Now, the communication plan must include all of the following things. You must have in your communication plan the ability to pull the names and contact information for your staff, the entities providing services under arrangement, that's your contract therapies, for example, contract social workers, and so on, your patients' physicians. How in the world are we going to get in touch with them in case of an emergency? Your volunteers, if you have volunteers working for you, the federal, state, tribal, regional, or local emergency preparedness staff numbers. Make sure when you contact them that you get backup numbers in case of an emergency, how to reach them. And then, of course, any other sources of assistance. Maybe you are trying to reach your medical supply company and so on. Those are the numbers that you're going to have as part of your communication plan. At 484.102C3, we also see that our communication plan must have primary and alternate means for communicating with the agency staff, federal, state, tribal, regional, and local emergency management agencies. How do you reach those if the phones go out? How do you reach those if cell phones go out? Do you have pagers? Do you have satellite phones? Or are you going to use the Army's or the military's ham radio system and so on? How are you going to communicate with these different entities? That's something that you'll have to put in your communication aspect of your emergency preparedness plan as well. At C4, we see that our communication plan must also address a method for sharing information and medical documentation for patients who are under the agency's care as necessary with other healthcare providers to maintain continuity of care. One thing to think about here at 484.102C4 is on your consent form, you need to make sure that you get permission to share certain pieces of information with other healthcare providers in the case of an emergency for HIPAA reasons. You don't want to wait until last moment and hand something off that you're not covered under HIPAA law to do so. That needs to be addressed well and ahead of time, and the patient in their training and teaching, which we are required to do as well regarding emergency preparedness, I would go over those specific reasons why I might share their information, and I would include in case of emergency and be a little specific as to what that means. With your communication plan, we see here at C5, we must also include a means of providing information about the general condition and location of patients under the facility's care as permitted by 484 CFR 164.510B4. At C6, we must also include a means of providing information about the agency's needs and its ability to provide assistance to the authority having jurisdiction, the Incident Command Center, or the designee. So again, your communication plan needs to talk about what you need and what you can help with to whomever has authority in your area. The next aspect of the emergency preparedness plan is found at 484.102 Section D. This has to do with the training and testing of your emergency preparedness plan. We see here that the Home Health Agency must develop and maintain emergency preparedness training and testing program that's based on the emergency plan that we talked about in Part A, about the risk assessment in Part A1, the policies and procedures that we talked about in Part B, and the communication plan that we just talked about under Section C. Now, the training and testing program, again, has to be reviewed and updated. How often? Say it with me, at least annually. They say that in every single part. So please don't get caught with your pants down, so to speak, and not have your plan updated and reviewed at least every year. The training program says that the agency must do all of the following. You must have initial training in emergency preparedness policies and procedures to all new and existing staff, individuals providing services under arrangement. Who is that again? That is your contracted employees. Volunteers, and that it's consistent with their expected roles. So you're training them not just on your policies and procedures, but also what they might be expected to do in their particular roles as a provider for your company. We see at D1, number 2, provide emergency preparedness training. How often? At least annually. Again, you've got until November to make sure that you're compliant with this, or you're not going to be compliant with the COPs when they're implemented. You must maintain documentation of the training. Make sure you have sign-in sheets. Make sure that you have documented what it is that you trained, a copy of the training that you used, a copy of the policies and procedures that you trained on, and so on. You want that documented very well. Make sure that your agency can demonstrate staff knowledge of emergency procedures. I would create a pre-test for them to do before the training, and then a post-test after they've had the training to help demonstrate staff knowledge. And you're also going to want to document when you do your desktop exercise, whether or not the staff were able to go through that exercise and understand what it was they were supposed to do, and that they were knowledgeable about that. And if they're not, what training you're going to do to make sure that they do understand, and then I would plan to do a second tabletop exercise until they're proficient in the procedures that you've laid out. At D2, we see that the agency must conduct exercises to test the emergency plan at least annually. The agency must do the following. You must participate in a full-scale exercise that is community-based, or when a community-based exercise is not accessible, have an individual facility-based full-scale exercise. If the agency experiences an actual natural or man-made emergency that requires activation of the emergency plan, then the agency is exempt from engaging in a community-based or individual facility-based full-scale exercise for 1 year following the onset of the actual event. That's a whole lot of words that just simply mean this. You are expected not only to do your tabletop exercise, but also have a full-scale exercise. And what they mean by that is like a disaster drill. You'll need to coordinate with your local area community emergency preparedness professionals and find out if they're planning on doing a community-based disaster drill. You'll see this often in the newspapers or on the television, where the EMS services have gotten together and staged a disaster drill. They'll have volunteers laid out in body paint, and they look like they've been maimed and bleeding and all of that, and they'll run through a community-based drill. You want best practice to participate in that. If there's a community-based exercise going on, you want to be part of that. But the regulation also says when a community-based exercise is not accessible, you should have an individual facility-based exercise. So if the whole community, the county's not going to do that, or the city, then you can certainly get together and pretend, you've had a gas explosion at the office, you got bodies laying around the hall and out in the parking lot, and you run through a community-based drill, if that's at all possible. And the only way you're exempt from that is if you actually have a disaster. If you have a tornado hit your office and you go through a plan, then you're exempt for a year following when that actual event happened. Aren't they kind enough to let us off the hook? All right, at D2, we see that we must also conduct an additional exercise that may include, but is not limited to, the following: a second full-scale exercise that is community-based or individual facility-based, and a tabletop exercise that includes a group discussion led by a facilitator using a narrated, clinically relevant emergency scenario and a set of problem statements, directed messages, or prepared questions designed to challenge your emergency plan. So your desktop or tabletop exercise is where you talk about, okay, here's the scenario. We are at work. We've been hearing that hurricane whatever's coming. It's supposed to make landfall tonight at midnight. We need to talk about what's going to happen. All right, sure enough, at midnight, the hurricane happens. We start contacting our employees and patients between now and midnight tonight. What are we going to do? You're going to contact and make sure they're evacuated, who's who's at home, blah, 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 blah. That's what you're going to be doing with that tabletop exercise. You're going to talk through all these different events and problems and how you're going to handle them. All right, at D2, number 3, we would then have to analyze the agency's response to and maintain documentation of all these drills, tabletop exercises, and emergency events, God forbid those happen, and then revise the agency's emergency plan as needed. All right, now we've made it through 4 sections. Let's go to the 5th section. At 484.102E, we address emergency preparedness when we are part of an integrated healthcare system. Now, an integrated healthcare system is when you have a home health agency that's part of a bigger corporation, let's say. Now, if your agency is part of a healthcare system consisting of multiple separately certified healthcare facilities, in other words, you might have multiple home health agencies, or you might have a home health agency that's part of a hospital system that also has a wound care center or a long-term care facility or a long-term acute care facility and so on. So separately certified healthcare facilities. If you're part of one of those systems and you elect to have a unified and integrated emergency preparedness program, then you can choose to participate in that system's coordinated emergency preparedness program. In other words, if you're all under the umbrella of Rush Healthcare Systems, you have Rush Home Health, you have Rush Wound Care Center, you have Rush Hospital, you have Rush Long-Term Acute Care Hospital, and so on. If Rush as a system wants to have an emergency preparedness plan that incorporates all of those entities, you can do that. And the agency can choose to participate in their coordinated emergency preparedness program. But if this is the route you go, your emergency preparedness program must do all of the following. Number 1, your home health agency must demonstrate that each separately certified facility within that system actively participated in the development of the Unified and Integrated Emergency Preparedness Program. So when they're doing their annual updates and writing policies and procedures for the whole Rush system, Rush Home Health has to be there and be a part of developing that emergency preparedness program. At E2, we see that program must be developed and maintained in a manner that takes into account each separately certified facility's unique circumstances, patient populations, and services offered. At E3, we see that we must demonstrate that each separately certified facility is capable of actively using that unified and integrated emergency preparedness program and that you're in compliance with that program. And at number 4, we see that we must include a unified and integrated emergency plan that meets the requirements of A2, A3, and A4 of this section. That unified and integrated emergency plan must also be based on and include a documented individual facility-based risk assessment for each separately certified facility within that health system, utilizing an all-hazards approach. And then finally, at E5, we see that emergency preparedness plan must include integrated policies and procedures that meet the requirements set forth in Part B of this section, a coordinated communication plan, and training and testing programs that meet the requirements of Part C and D, respectively. So basically, they're just saying here in Part E that if you're going to be part of the Rush umbrella, we'll just continue to use that Rush example, that you still have to meet all of the different sections as if you were an individual, but you can do that under the umbrella. So you're still going to have documentation that you participated in the drills, all of that stuff that we talked about early on, but you can do that as part of one big system and one big umbrella that looks at each different healthcare entity underneath that umbrella. Okay? Now, we've gone through all the guidance as far as the actual conditions of participation regulation. Now I want to talk to you a little bit about some different factors that CMS have given us regarding emergency preparedness, some things that maybe are shortcuts or will help ease the burden during an emergency. Per CMS, during a declared emergency, agencies may complete an abbreviated OASIS in order to assure proper treatment and payment. So if it's time for a start of care or a recert or a post-hospital visit and it just happens to fall during an emergency, you can do an abbreviated OASIS. Now, a couple things to think about outside of the actual home health conditions of participation regulation that we've just covered. We have received some clarification from CMS regarding certain regulations that we have to deal with, particularly as it has to do with the OASIS. So per CMS, during a declared emergency, the agency may complete abbreviated OASIS to ensure proper treatment and payment. So if you have an extended declared emergency and you have patients who need recertifications or starts of care or post-hospital assessments, for example, we can do an abbreviated OASIS in those cases. Per CMS, during the emergency period, a home health patient's place of residence can be any of the following: a family member's home, a shelter, a community facility, a church, or a hotel. And that's good to know because sometimes if you're going to do a start of care and you're thinking, well, they don't live anywhere, they're in a shelter, they're homeless. No, if it's an emergency period, that shelter will qualify as their place of residence. Per CMS, during declared emergency periods, the following home health patient's place of residence may not be a hospital, a skilled nursing facility, or a nursing facility. Clearly, if they're in one of those settings, someone else is billing for their services, and we are not allowed to do the same, so that is not a place of residence. If you're looking for that particular regulation, you see the link here on the slide. That's where I got that information. It's an All Hazards FAQ PDF. Real good to download and read regardless, but those were some good pieces of information that were gleaned from that particular FAQ page. There's also some information on CMS's emergency preparedness website that talks about 4 core elements of emergency preparedness. So keep this in mind as you're working through those new COPs and the new emergency preparedness final rules. There's 4 key elements or 4 core elements: your risk assessment and emergency planning, your communication plan, your policies and procedures, and then training and testing. Those are 4 separate entities that you need to make sure you're taking care of. Remember, your risk assessment and emergency planning includes, but not limited to, hazards that are likely in your facility's geographic area, any care-related emergencies, your equipment and power failures, interruptions in communications, including cyber attacks, loss of all or portion of your facility, a loss of all or a portion of your supplies. And remember, that plan has to be updated how often? You're going to get tested on that annually. The second part of the emergency preparedness plan is your communication plan. Ensure the following happens: that you comply with federal and state laws, that you have a system to contact your staff, including your patients, physicians, and other necessary people, and that it's well coordinated within the facility, across the healthcare providers types, and within state and local public health departments and emergency management agencies. The third of the 4 key elements of your emergency preparedness plan are the policies and procedures. When you're writing policies and procedures, ensure the following: that they comply with federal and state laws, that they also comply with your accrediting body, Joint Commission, CHAP, ACHC, for example, and that your staff are oriented and understand your policies and procedures. The last key element or core element of your emergency preparedness plan is your training and testing. You have to make sure that it complies with federal and state laws, that you maintain and update your emergency preparedness plan, and that you train and test your employee knowledge at least annually, and that you do a desktop drill or tabletop drill and a community-based drill each year. All right, next I'm going to give you some resources here where you can look at additional information on the emergency preparedness program. The 4 core elements of emergency preparedness are found at the website that you see here on the slide, and they are applicable to all 17 provider types, which include home health and hospice. You'll also notice that there are comprehensive emergency management phases, which are your hazard identification, hazard mitigation, preparedness, response, and then recovery. What's the recovery phase? What are you going to do when the event is over? How are you going to recover and get back to normal? With hazard identification, for example, that's the all hazards approach. You have direct hazards, which is when your facility is hit. Then you have indirect hazards, which is it happened somewhere in the community, but the provider itself is not exactly hit. So you may have an interruption of utilities or supplies or staffing, but your office is not necessarily a direct hit. An all hazards approach includes all these different types of emergencies. You have natural disasters, things like hurricanes, tornadoes, severe storms, flooding. You have man-made incidents like bioterrorism, radiation, chemical emergencies, or mass casualty events. Then you have public health like pandemic flu and biological hazards. Once you have figured out all the different hazards for which you are at risk at your location, the next part is to mitigate those hazards. And this is where you look at the activities taken to eliminate or reduce the probability or reduce the severity or the consequences of that emergency. This happens either before or following a disaster. Best practice would be, if you have a hurricane, for example, to begin to mitigate those hazards before. But sometimes you won't have warning, so it might happen after a disaster. You should include mitigation processes for both the patients and the staff, and you should have comprehensive efforts including your staff education. The third part we saw was preparedness. We want to develop a plan of how the agency will meet the needs of patients if essential services break down as a result of the disaster. You're going to have a product of review of a facility's hazard analysis and analysis of the provider's ability to continue providing care and services during an emergency. You're going to have staff training on their role during the emergency plan. You're going to test the plan and revise the plan as needed. And you see all of these concepts have been included in the Home Health Conditions of Participation's emergency preparedness rules as well. The fourth part we see is the response. These are the activities immediately before if you have an impending threat, during and after an emergency. And the idea here is to address the immediate and short-term effects of your emergency. Last, you have your recovery phase, and those are the activities during and after a response, and they're designed to return the facility back to a usual state or your new normal in some cases. Next, I'm going to give you some examples of some emergency preparedness tools that you can use in creating your own emergency preparedness plan. Two of the best ones I know of, you see here on the screen a snapshot of what they look like. The first one is the Maryland National Capital Home Care Association's Emergency Preparedness Manual. It is a PDF that's downloadable from their site, and it has checklists, and I'm going to show you some little snapshots of that in just a moment. It has checklists for your hazard assessment and all kinds of handouts to give to patients, some of which are in different languages and so on. It's really, really good. The one on the right is the Emergency Preparedness Packet. It's pretty old, but it's from NAHC, the National Association for Home Care and Hospice. And so this one's back in 2008. I wouldn't doubt that NAHC puts out an updated one at some point, but I have no idea the timeline or if they even intend to do so. But the Maryland National Capital Healthcare Association, Home Care Association, they did theirs more recently. It's maybe a couple years old at the most. And again, you still might have some fine-tuning to do, but a lot of the work's already been done for these two particular emergency preparedness tools. For the Maryland National Capital Home Health Association, you've got their web address here with the resources. It's my personal favorite. It's a free emergency preparedness resource. It's a 5-part booklet. The 5th part is the state and local contact information, so you will have to amend that to include your local contact info for your state and local entities. As I said before, it does have several handouts for patients and families. It's got multiple language translations, and those handouts are things such as, telling the family, making sure they have like a Rubbermaid container that they can put adult diapers in and medications and supplies, and making sure they have backup oxygen tanks and a full tank of gas and blah, blah, blah. So all of that's really good information, and your surveyor will love to see that on survey. They had a federal grant actually to put that booklet together, so it's very well done. The Hazard Vulnerability Assessment Tool, you have an exhibit here out of the Maryland Association, so you can see a sample of how they go through each different type of event and the probability level for that particular event, or the vulnerability level. Are they going to have a total disruption, a moderate, or a low? And then a preparedness level. Good, fair, poor. How prepared are they for that? Another example tool out of the Maryland National Capital Association's emergency preparedness booklet that you can download. This one is a home care emergency preparedness assessment, and it talks about, it's mostly a checklist here at Exhibit B. This is only part of that you can get, but of course it makes sure that you have, with this checklist, all of your different aspects lined out. For example, do you have access to your updated census? Can you identify the patient's acuity levels and so on? So these are just samples of what you can get from that downloadable tool. The tool that I mentioned from the National Association for Home Care and Hospice, here you'll see the website so that you can get to that. Again, it was created in 2008, so it might be a little out of date. Do know that our own executive from the Texas Association for Home Care and Hospice, Ms. Rachel Hammond, was on the committee that created this particular resource. So of course, we're proud of that, both because of Rachel and also because of the National Association fixing this up for us. This one may not be quite as pretty as the Maryland example. It will probably require a few more updates, but just know that these are two great tools to help you create your own emergency preparedness tool. And then you've got a hazard vulnerability assessment here as well. It looks a little bit different than the first one, but it's the same principle. You look at the probability. Is the probability high, moderate, or low? And then your level of vulnerability or degree of disruption. And then the preparedness level. Are you prepared or not for that? You also see this particular tool from the NOC tool that talks about the date that you completed the different pieces for your emergency preparedness and who was responsible for completing those. Last, I want to just give you a couple of examples just to give you some ideas as you're thinking about emergency preparedness. These are some examples of declared emergencies that our government has declared. Most recently, we had a large-scale cyber attack where 150 countries were affected back on May the 12th of 2017. You think about what might happen if your EMR were attacked. For example, what would you do? That's going to have to be part of your emergency plan. Another example is the Zika virus outbreak in 2016. You had Hurricane Sandy in 2012. You had a Missouri tornado and severe storm outbreak in May of 2011. That was followed by North Dakota flooding in April of 2011, I should say. That was preceded by, let me say that again. We had a Missouri tornado and severe storm outbreak in May of 2011 that was preceded by North Dakota flooding in April of 2011. We also had flooding in North Dakota in March of 2009. So if you're in North Dakota, you certainly need to plan for flooding, apparently. We had an H1N1 flu outbreak in April of 2009. Flooding again in North Dakota and Minnesota in March of 2009. And then here's where we get hammered in Texas. We had Hurricane Ike, September 2008, which affected Texas and Louisiana. We had Hurricane Gustav in August of 2008 that affected Louisiana, Texas, and Alabama. And the list goes on, as you can see here. The one that's probably most notorious to most of us, at least here in the southern states, is Hurricane Katrina, because it was such a big, massive hurricane, Category 5, and it hit so many states and affected so much of the middle part of our nation. And that was back in August of 2005. And this is really where we started to test that emergency preparedness plan that went into effect in 2003. And we really noted a lot of holes in the emergency plan and had a right on the dot test that showed us that we had a lot to work on yet. So Those are just some examples of things to think about. Lastly, I have you some websites here for resources. You have a 2016 CMS presentation on the Emergency Preparedness Final Rule and Plan. That's an audio and visual that you can listen to after the fact. It's recorded. There's also the link to the Emergency Preparedness Final Rule. Again, this is the one that came out in September of 2016 that finalized the emergency preparedness regulations and told us that that goes into effect in November of 2016, which means we have to be compliant by November of 2017 as well. Last, you've got CMS's interpretive guidance that recently came out. This is your surveyor's guidance. It tells you what the surveyors will be looking for when they come into your office as they're assessing your emergency preparedness plan. And then you have healthcare provider guidance right after that. The general resources list is here, as well as your HIPAA indications. Again, we mentioned those during our webinar today, so these are the information pieces where I got the information and where you can go and read more. Last, you've got an emergency response and recovery website and the recorded webinars that we mentioned before. And then we have Maryland National Capital Home Care Association's Emergency Preparedness Resources and Manual link again for you there. Now, since this is not a live webinar, you will have to address your questions and answers to me remotely. You can do that by email. My email and cellular number are listed on the slide here, and the best way to reach me is by email or text message. You can certainly leave a voicemail message on my cell number as well, but those are the best ways to reach me since I travel a whole lot as well. Okay? We hope that you've enjoyed our webinar today and the series on emergency preparedness. We thank you for trusting us with your education needs and certainly look forward to helping you in any way that we can. Have a wonderful day and thank you.
Thank you for joining our on-demand training today and for choosing Access, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Access is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at access.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Access.